The following presentation will attempt to assess how we've reached the current stage of the COVID-19 pandemic, explain more detail about the virus itself and the epidemiological considerations and issues, and also ultimately attempt to map out future trajectory and how the pandemic evolves and ultimately ends. Just then to explain precisely how we'll work through this, to begin with a little background on the virus itself, its nature and what we currently know about its clinical presentation and spread. Second background, really explaining how from the initial outbreak in Wuhan, we've now spread to reach the stage of the WHO declaring this a pandemic. Next, a consideration of the current state of play and an attempt to explain the epidemic curves that we're seeing, what that means and how those evolve and are influenced by public health intervention. In that context, we'll have a quick look at a case study of a situation in Scandinavia comparing Sweden, Denmark and Norway and their approaches to combating the disease, which provides a useful basis for comparison. We'll then consider next steps. Where do we go from here once the initial efforts to suppress the virus and the country-based epidemics has enjoyed its initial success? And in that context, we will then also consider a case study on South Korea, one of the more successful countries to date in dealing with COVID-19. We'll then briefly touch on how a pandemic ends, try to give some timeframes for how things are going to progress over the coming years, and finally a conclusion which really will look at framing everything and trying to help understand the issues around attempting to forecast and gain clarity in predicting where all this goes and the pitfalls particularly involved in doing so. What is a virus? In simple terms, a pathogen or infectious agent that replicates only within the living cells of an organism. As a result, viruses are distinct from bacteria in that viruses always require a host and cannot reproduce independently. As a simple three-part structure with a marker protein as well as a fourth component, so that the structure itself in basic terms involves firstly the genetic material, so the DNA or RNA strand, which essentially sets out the code, if you will, information that the virus uses to hijack the reproductive elements within host cells to produce copies of itself. There's also an inner protein coat known as a capsid and an outer membrane in most viruses known as the lipid envelope, so made up of fat cells. And lastly, there's a protein or what's known as an antigen. In essence, this is crucial for the virus to tag onto cells that it wishes to target and enter, and it will be linked to a specific receptor on a specific type of cell. So in the case of the COVID-19, it attaches to what's called ACE2 receptors, which are prevalent on cells which line the respiratory tract, which explains why it is predominantly a disease of the throat and more significantly the lungs. Just in very brief terms about how the virus itself reproduces, so we'll attach the outer membrane of the cell via the antigen receptor link that I just discussed. Once it's in, it sheds its outer coat, so exposes that genetic code that I referenced. That then enters into the nucleus and the ribosomes and the Golgi apparatus, which are the tools by which the cell reproduces itself. That then produces even more of these strands of the viral code, and these then exit the cell, typically killing the cell in the process, but obviously then moving on to target new ones, and that obviously has a multiplying effect over time. Considering the coronavirus family itself, question of why call this a coronavirus? Very simply, appears under electron microscopy to have a sort of corona or crown around its outside, a little bit like if you imagine the corona that surrounds the sun. So very simple. These viruses are pretty common, in mammals, so generally involving a single strand of RNA, so a very simple structure. First discovered in chickens in the 1930s, have since been found in various animals, and you will no doubt have seen in the context of COVID-19 speculation about whether it came from a pangolin or from a bat, and whether dogs and cats are now infected. These viruses have been prevalent in humans really since the 1960s. May well have been that they were circulating amongst human populations before, but that was when they were first discovered. So there are 7 human coronaviruses, so 4 of them very common, which you will all likely have had in your lifetime if ever you've had a cough or a cold or a sore throat. But those cause very few problems. There's 3 which are of more concern. So this would be SARS, the severe acute respiratory syndrome, MERS, Middle East respiratory syndrome, and now COVID-19, which is also known as SARS-CoV-2, a marker of how similar it is, at least on a genetic basis, to SARS. There are, however, important differences between COVID-19 and SARS and MERS. I think the most immediate one to flag out would be how deadly the respective viruses are. In the case of MERS, 30% of those infected died, which obviously is a very high mortality rate. With COVID-19, we don't know if you were to take the current numbers via the Johns Hopkins University COVID-19 map, you'd see around 1.4 million cases confirmed and 80,000 deaths, which would give around a 5% mortality rate. That's unlikely to be, the figure in the final reckoning, and will largely as a result of the fact that we simply don't know how many cases there are. There's a widespread disagreement about how many people are simply asymptomatic, with studies from Iceland showing somewhere in the region of 50% of people may simply just not know they've had it. But that figure potentially even higher. And also there'll be many people who have a mild form and are aware they have it but simply don't get tested. So in the end, the best estimate at current time would be that the mortality rate will be somewhere between 1 to 0.5%. Which obviously is far less deadly than SARS or MERS. However, the problem really with this, and the key thing to bear in mind, is the way in which so many people are so mildly infected. The virus has a long incubation period, meaning that people, even who end up symptomatic, have it for a long time without knowing they have it, and are going around shedding the virus, spreading it. And the real difference then, particularly with SARS and MERS, is severity and how acute severity develops. So within those other coronaviruses, particularly MERS, it would immediately present as a severe lung infection, which and also there was little evidence of asymptomatic transmission before developing symptoms. As a result, it's much easier to contain and stop the spread of a virus like that, whereas COVID-19 is much more insidious in that the initial infection appears to target the throat, where the symptoms are relatively mild. You carry on, you may imagine you have a cold and flu, and then a progression of time, 2, 3, 4 weeks later, you see a sudden decline as the lungs are attacked, and a more severe clinical picture develops. And so that really is at the heart of why this is such a problem and why it's been so difficult to deal with the spread. You would see an excellent example in current affairs of that progression via the UK Prime Minister Boris Johnson, who from first presenting or announcing he had symptoms was able to continue to do a degree of work and be seen on the doorsteps of 10 Downing Street applauding health workers, but now some 2 weeks later has been admitted to hospital with a more significant problem. In terms of risk factors, the number one things to flag up seem to be age and gender. So the older you are, the worse this gets, and that effect seems to increase with age as well. So those in the 50 to 60 group are struggling more than those in the 40 to 50 group. But then once you get into 60s, 70s, 70s, 80s, the picture gets worse and worse. In terms of gender, this is disproportionately impacting men, although it's not entirely clear why that would be the case. Some suggestion that's to do with smoking rates. And obviously underlying conditions are a huge issue. So obesity, diabetes, those who are immunocompromised, and perhaps those also with past lung infections. There's a slight difficulty, particularly in trying to work out the impact of this in developing countries where a lot of younger people may have a higher prevalence of certainly respiratory diseases, tuberculosis. The extent to which that will outweigh the benefit they get from being young in combating this and fighting it off is unclear. One thing that we can say with general confidence, and seems to be consistent across different countries, is the progression that about 80% of people, it's ranges from no real symptoms to unpleasant, but no more severe than that. For 15%, they will probably need some degree of hospital intervention, and then 5% people progress to a critical stage, needing access to ICUs and consideration for ventilation. In terms of the treatment, there's no antiviral yet, so it's really a case of managing for medics. That will be support via ventilation, fluid management, and such as that. There's also progress and case studies showing it's not just the lungs, but it will all move on to target the kidneys, in which case people may need dialysis. But in essence, it's all about buying time for the immune system itself to fight things off. In terms of how we've got to the present day, in terms of timeline, the key initial event was on the 31st of December, when the Chinese health authorities first reported a cluster of abnormal pneumonia cases, all of which were linked to the wet market in Wuhan, which we will all have heard so much about. The first death from COVID-19 followed on the 11th of January, and the first case outside China being reported in Thailand on the 13th. On the 30th of January, the WHO declared a public health emergency, and significant outbreaks outside China developed, firstly in Iran on the 19th of February, and then the 21st in Italy, with others following worldwide, prompting the WHO finally on the 11th of March to declare this a pandemic. Why has this been so severe, particularly if you think back to past major public health global issues, including the bird flu, swine flu outbreaks, as well as SARS and MERS? I think the first thing is that the nature of the virus itself remains crucial. So that asymptomatic spread, and the fact that it seems to be spreading very widely and rapidly, means that obviously, despite its lower mortality rate, the overall incidence of disease is so much higher, meaning that even with that low mortality, it's a major public health crisis. So those biological factors are crucial. That's not to deny political failures. It seems clear now that Chinese assessments and data early on and continuingly were not necessarily accurate. I think there's probably a perception in the West that this was going to be like SARS and MERS and these other issues, by which I mean something that would be contained to Asia, not going to be a global problem. I think the fact that it's a novel pathogen is crucial. Again, we can only understand so much, and whilst our understanding increases day by day, there's always a lag in understanding, which gave this virus particularly time to get off the ground. And you'll see as well failures at a global level. The WHO reporting this tweet on the 14th of January, which it obviously is a huge statement to make, and would be hugely reassuring to anybody who read it at the time, but not accurate. Will have doubtless played a role in undermining preparation. And lastly, the political angle. I think the prevalence of populist governments and disdain of experts that we see as a result has had a significant impact here. There are obvious examples in the US, but we'd look at Brazil as a really important example of quite how badly this is being managed in some countries, still with President Bolsonaro there effectively denying and undermining the public health message of state health authorities. That is really compounding things. I think the last thing then would be on this to consider, was this a black swan? Was this something that could not possibly be foreseen? I mean, I think you will probably have realized yourselves that during the last 20 years, we've seen coronaviruses make the leap from animals to humans and pose significant public health threats. So SARS and MERS, that's notwithstanding swine flu, bird flu. The idea that this was something unthinkable that we couldn't possibly be prepared for simply doesn't stand up to scrutiny. And I think that is something which will have important long-term impact. We will get to that later. Where are we now? Well, we have a declared pandemic. That in itself is something of a woolly term, rather ill-defined. I think it perhaps, whilst this clearly is a worldwide problem, worth considering it as a series of epidemics within individual countries. And obviously, people at different stages. We have Wuhan emerging out of lockdown with the government there easing restrictions and attempt to get back to some sort of normality. In the US and UK, you're just about to approach the peak of numbers of cases. In Italy and Spain, that probably is now reached and hopefully soon receding. There will be other places, significant populations, India, for example, where the outbreak is just beginning. And so it's a diffuse spread across the world of different experiences and different positions. In terms of understanding, the epidemic and how that peak develops, the curve, the most crucial underlying principle is that of the R0, or the basic rate of infection. In a nutshell, this is simply a single or double figured number which states how many people any one infected individual would be expected to go on to infect. If you imagine in the case of COVID-19, there's various estimates somewhere between 1.4 to 3.9. If we take 3 as a figure in that, effectively one person would be expected to infect 3. Those 3 would be expected to infect 3 further, so 9. Those 9, 3 further, 27, and so on and so on. And so you can see how the higher that number, the more quickly the number of cases rises. Whenever the R0 is above 1, you'll get an increase, a rise in the curve. So if you look at the black line here, so from around April the 20th up to May the 20th, on the graph, you'll see quite a steep rise. That in effect, whilst I wouldn't have the precise R0 to hand, is simply a reflection of that being above 1. And that means that the number of people infected continues to rise. However, that black line there is a do-nothing scenario. So this effectively means, what would happen if you just carried on as normal and let the virus go through the population. You'll see eventually that curve begins to reach a peak and sort of flatten out. So what that is, mathematically speaking, is that the R0 approaches 1, the curve flattens, and then when it reaches 1, the curve is level. So right at the peak, you'd say there the R0 is 1. If you imagine then what does an R0 of 1 mean? Literally just a sort of slow accumulation. So for every one person will infect one person, who will then infect another person. And it's a very steady accumulation of cases, a flat line, not a rising line. Why then does this happen in a situation where you've just allowed it to propagate through the community? In simple terms, eventually any virus will run out of people to infect. So with each advance up this curve, those people have been infected. They would, in theory, if they don't die, develop immunity. And so given that the virus has fewer hosts to jump into, naturally that R0 decreases. That's not to say there's any change in the virus's behavior. It's simply that the pool of available hosts diminishes. It has fewer opportunities to spread, and so its propagation is slowed. And eventually you hit a threshold, which is when the curve starts to come down, when the R0 has fallen below 1, simply meaning that everybody infected infects less than one person. To sort of explain it a bit more clearly, it's worth sort of scaling up numbers. If you imagine you had 1,000 people infected and the R0 was 0.5, that 1,000 people would infect 500 people, who would infect 250 people, who would infect 125 people, tending towards 0. And the epidemic then tails off, which you'd see at the end around the July 20th date there. It flattens and reaches that. So, that in basic terms explains how an epidemic rises and falls, and that would be the same for more or less any disease where people acquire immunity and the pool of targets for the virus declines. The problem with that, which again will probably be familiar with you, is that health services can't deal with the capacity of or lack capacity rather to deal with such a heavy influx of cases. As you'll see, we're looking at what would be a very narrow timeline for all those people. If you take a hypothetical country with 100 million people, and we assume a mortality rate of 1 to 0.5%, you're talking about 1 million to 500,000 people dead within a 3-month span. Obviously, no healthcare system could possibly accommodate that. So we intervene, and in doing so, that is all about, again, a function of this R0 and implementing it. So if you take the light blue line here, so case isolation, home quarantine, social distancing of over 70s, by doing that, by separating people, because the virus is spread by respiratory droplets, coughing, if you keep away from infected people, you cannot get infected. And so that naturally means that the R0 falls. If you imagine that it has an R0 of 3 if you do nothing, but then one of those 3 people you would have infected doesn't go out the house, well then the R0 naturally falls. One of the consequences is a flatter peak, but also you'll see that the tail on the right hand side lasts a little bit longer. Why is that? That's effectively because there's still that pool of people who aren't infected, who the virus can target. So, letting it go through the population builds that brutal peak, but ends things quicker. With this, it means that things continue. And obviously as well, there's the potential for them to come back, because the total number of people infected is reflected by the area under each of these curves. So you'll see how for the black curve compared to the light blue one, that's a much larger area under the curve and a much larger number of people who've been impacted. In order to help understand that a little clearer, it's worth putting this into context with some real life data. What we see here is a graph relating to Scandinavia, and I've chosen this example because the 3 countries, Norway, Denmark, Sweden, provide a good basis for comparison, as there's a lot of underlying similarities in terms of population, strength of the healthcare system, human development. So they provide a good way of considering the impact solely of public health intervention and R0. For those of you who don't speak Danish, very simply, the x-axis here, well, you will already have intuited, is the date. The y-axis is number of cases. So what this is showing at each data point is the number of new cases on that day. So if we take the yellow line, the Swedish line, we see the R0 there, very clearly above 1. That reflects the fact that Sweden, distinct from Denmark and Norway, has adopted a much slower approach, less quick to lock down an attempt to keep things open on the basis that, in the chief epidemiologist's eyes, such lockdowns simply aren't a sustainable or viable strategy. What are the consequences? Well, as you see, the number of cases in Sweden already far higher, and the rate of daily cases accelerating. If you then compare that with the red dots there, so that's the Danish position, you'll see there was that rise, so the R0 above 1. However, in that period between 25th and 30th of March, you can see that bending of the curve, which reflects that R0 tending down towards 1 and probably reaching it. So if you see between 29th and 30th of March, we'd say there that's an almost precise demonstration of an R0 of 1, and would hopefully then begin to tail off as R0 declines. In the Norwegian case, the light blue line, you can see that they're still beginning to rise, so R0 is still above 1, although probably not by very much given the very low level of rise in that curve. And again, I would probably hope, I haven't seen the data since, but that to flatten fairly quickly and keep to a very low peak. And so that will probably be borne out not only in seeing those Swedish case numbers over the coming weeks continue to rise, but the ultimate death toll as a consequence ending up being much larger. The big question, having successfully flattened the curve, driven R0 below 1 and seen case rates fall to low levels, then becomes, as you will all be aware, how do we then get out and move away from lockdowns? Obviously, the first and crude way out would be simply to end the lockdown. You'll see that the light blue curve here provides an illustration of why that is a bad idea. You'll note from 0 to 6 months great success in suppressing the rate of infection and the spread of cases. However, then you lift it and then an immediate rebound into that typical epidemic curve, which obviously you don't want, because you're then back in the territory of R0 skyrocketing and the potential impacts on your health service. So what's the way out? Part of it would be to consider partial easing. How will that work? I think there's numerous ways that you could approach this. One example might be to look at it geographically. If there are areas that have experienced their peaks, particular urban centres, allowing relaxations to an extent there. You could then also hopefully relocate resources and healthcare staff to other areas that are worst hit and adopt a sort of rolling geographical basis like that. There's other ways you could also consider it a demographic approach. Whilst obviously there are younger people who are adversely affected by the virus, it's not solely the old. The mortality rates, particularly in the under 30s, are much better. Obviously, you will have seen highlighted cases of healthcare workers, young people dying. That probably is a factor potentially of genetic susceptibility, or, and I think more work needs to be done, but it seems logical that those in that healthcare setting, particularly if they lack adequate personal protective equipment, are receiving a higher dose of the virus, a higher load, and thus are experiencing worse clinical outcomes than others within their age cohort. But so you could, on that basis, allow those between 20 to 30, or other segments back out to begin work and to get out, because if they do get it, the risk is less, and you will build up a degree of that herd immunity whilst continuing to shield older, more vulnerable generations. You could also consider, whether it's just specific institutions, as schools might be a fine example. If you have young staff who are able to go and teach and help out with kids who, again, aren't suffering significantly from the disease, then that's another way of doing things. So a lot of strategies around this. But obviously within that, you would have to maintain a lot of measures already in place, social distancing, the use of masks, although there is an ongoing debate about how helpful that is. In itself, it's helpful, and obviously there's a sense in trying to get some return to economic activity, particularly. However, with this, there's always the risk, particularly of a lack of compliance. Also, if you're allowing certain groups out and not others, that creates political difficulties. How do you ensure compliance? And there's always a risk with this, a partial easing, that you then get a new cluster, your R0 drives up again, and you're back to square one and needing to reimpose a lockdown. How then to manage that issue, and the fact that in isolation, partial easings of restrictions will have a benefit, but with potential risks? I think the key would then be to complement it with a testing regime. So obviously, you will have heard a lot of discussion about testing. It's probably worth being clear about what that actually means. There are two kinds, the antigen and antibody. Antigen, as you will recall from the earlier slides, that is really just a way of testing, do you have the virus in your body? So if I take a swab from your throat and then run the relevant tests, would I detect that viral antigen of COVID-19? If so, that would tell me that you have it, even if you don't have symptoms. What's good about that? Well, if you are symptomatic, then there's potential you'd be identified, and if you're going to worsen, you can then be more easily and quickly taken to hospital and necessary precautions taken. So that's good from a personal outcome, but from a public health point of view, means that you can be isolated, quarantined. There can be then contact tracing. You can work backwards and try to work out, perhaps for how long things have been incubating, and try to work out where you've been in that period and let people know. And they can then take necessary steps, and in that way you contain that cluster almost, which again is positive in R0 terms. If you do that alongside those partial restrictions easing, you're then having a much better effect and a much greater chance of avoiding another re-emergence of an outbreak. The second test, the antibody test, this is a little bit more complicated. You'll see the attached graph. What this shows is, if you take the blue line, that is, again, it's not precise, these dates, but the blue line would be the amount of virus of COVID-19 circulating within your blood, so a measure of that. What happens is, as that rises, that triggers an immune response. So you'll see from day 7, IgM becomes detectable. So IgM just means immunoglobulin M, which is a type of antibody, a class of antibody released by your immune system. This, as you'll see, is a helpful immediate response, but it sort of peaks quite quickly, IgM. So once the viral load has started to come down, that will begin to tail off. However, that red line, the IgG, immunoglobulin G, is an extra sort of component of the immune response, which is fired up a little bit later, but it plays a greater role in limiting the risk of infection over a longer term. So IgM is kind of a shock, whereas IgG persists over longer. And if you look at day 28, you'll see that's when there's a peak of IgG in the blood, which provides that long-term immunity. So for an antibody test, you will probably have heard that 28 days after infection is the optimum time to test. That's why, because it will be when the IgG level is at its highest, so the test will be most accurate then. What's the use of that? Well, I mean, it's great to know if you've had it, particularly if you're a health worker, or otherwise essential or even non-essential, because it then would allow people to return to a degree of normality because they're not a risk. Obviously, that's contingent on some things we don't know, particularly about how long immunity lasts. So you'll see that red line on the IgG goes to 35 days. Obviously, how long that immunity lasts is an open question. We don't know yet. But in theory, if that gives you, 6 months, a year, then that's great, because then you can get out and be working. And also, using these antibody tests would ultimately allow, by sampling methods, to get a knowledge of what the disease burden across all of society is. And from that, if you knew roughly what percentage of people had it rather, and currently have it, that really helps inform your public health response. You will also perhaps have heard the term serology or serum testing. That is antibody testing is what's meant by that. Added into that becomes public health measures and knowledge. So it may be that we come to see that different distancing measures have different impacts on R0. If it was shown that, extending things to 3-4 meters, social distancing when out and about, obviously there are practical difficulties, but that would help allow more people out, provided people obeyed those rules. The role of masks, which again, as I've said before, is an open question currently, would be another to consider if it was shown that by wearing masks, as the emerging logic goes, there was less of a risk of asymptomatic people spreading the virus. That would obviously be another benefit for maintaining that R0 at a lower level and allowing people to go about a degree of daily business. But again, all of this is quite contingent on understanding that we don't necessarily have yet. So it will be a movable feast in that sense. And then lastly is treatments and system capacity. Obviously, if a game-changing antiviral were developed that meant that 80-15-5 rule I discussed earlier shifted to 95% of people just being able to deal with it at home and a much smaller number ending up in critical care, then naturally more people could, once that drug was massively available, you could get a diagnosis and get treatment through primary care rather than having to go to hospitals, and that would be a huge benefit. And also increases in healthcare capacity. So if you have more beds, more ventilators, and better clinical outcomes for those who end up in intensive care, you can, in theory, tolerate a higher level of R0 and a higher degree of infection than you would be able to otherwise. Although, again, you'd still be faced with the risk of a major spike, which you would want to avoid. So I think it's really key thing to understand is that it'll be a synthesis of these measures that will be key to easing things and allowing some degree of normality, such as it is. What does the future look like? South Korea may be a very good example to point the way. Just to explain the curves here, so the blue line there represents the number of increase in daily cases. As you see, there was quite a robust lockdown. You then end up with a peak 35 days since the first case, and then from day 45 onwards, again, you have an almost perfect example of what an R0 of 1 looks like. So you've got a sustainable number, about 100 new cases confirmed every day. So that's very positive in terms of meaning that whilst there is always that risk, as discussed, because of the nature of disease, you will still have these new cases. Eliminating entirely is very difficult, but you're avoiding that big spike, and that means that the healthcare system isn't overwhelmed and can deal with cases. How have we got here? Really, it's that combination, as I've just discussed, of isolation case tracing approach. So there have been some restrictions lifted, and South Korea largely avoided the kind of lockdowns we've seen because it carried on with that testing and isolation and case tracing approach, which meant that it was from that very early stage continuing to intervene in a way more proactively than in Western governments. If you see what the UK, US, Italy, Spain have had to do, in the end, they weren't able to maintain the testing. It moved to a mitigation strategy, and only now is there a catch up to realise that that mass testing, isolation, case tracing approach is the way to go. Better late than never. South Korea, though, is an example, in terms of what resources needed. So testing levels there are around 8,000-9,000 tests per million of population. How easy is it to repeat this scenario? Well, in the more developed world, wealthier nations, yes, eminently plausible. However, Iran, as an example now, denied resources and international aid, and impoverished by sanctions and a degraded healthcare system as a result, it's unlikely it would ever really be able quickly enough to get to that sort of mass testing level, that will help. And so the ability of those countries who just simply can't get at the material will be difficult. Also, large countries with diverse, diffuse rural populations, India, Indonesia, this is likely to be a huge challenge trying to do this. However, it's an example of how those strategies can work and keep a degree of openness and allow an economy to continue working without those big spikes. You will, however, note the less positive deaths line. So obviously the numbers involved aren't too large, talking about 5-6 deaths a day. However, you'll see that that number continued to rise sometime after the peak number of new cases. So to bear in mind with all epidemics in your countries, unfortunately, whilst there will be that positive news that comes about the peak in cases, the positive news about peak in numbers of deaths will lag that and lag it by quite a while. That is a reflection, as discussed earlier, about the way in which the disease progresses. So milder form for 2 weeks a month before progressing to a more severe form. How does all this end? I think really a variety of ways, but the ultimate point, and again, this will take you back to the first discussion of R0 and how that epidemic curve works, that eventually the way it really ends is that the virus runs out of people to infect or cannot infect any longer. See the public health measures there, that really is a reference back, as highlighted throughout this, to the SARS-MERS outbreaks. There was a lot of work intensely that went into trying to find a vaccine for it. In the end, that was abandoned because in both cases, and particularly in MERS, where it happened even quicker, the nature of the virus and the fact that it only really spread once symptomatic, and once symptomatic became very severe, meant that by public health measures, it was easy enough to contain, and there was no need for either herd immunity or a vaccine. So it was brought short, although the potential risk of further outbreaks, but again would be more easily contained unless there was significant change in the viral behavior. Herd immunity would be the ultimate backstop. So with any disease at all, even if you can't contain it or find a cure for it, and you'll see in the attached diagram, eventually you reach a threshold where so many people have had it and have immunity to it and cannot be infected and thus cannot spread it, that you effectively disrupt the chain. Obviously, it depends, for what the R0 of disease is. So one of the most infectious diseases, if you don't intervene, with measles, the R0 is around 12 to 18, so that propagates enormously quickly. And for that, I think the figure is around 90% of the population who are vaccinated, in countries that provide it with the MMR vaccine. That's achieved, but it's a high level for something of COVID-19 scope. An R0 in the 3 region, you're probably looking at something in the region of 60 to 70%, which would be somewhere in the region of 5 billion people, which obviously is a very large number of people worldwide for that to reach. Obviously, however, we would hope that we can intervene and do something more quickly than that through a vaccine. That's what we all obviously are hoping for. So there are, at the time of writing, I believe 47 different proposed vaccines in development. One thing to consider is we never managed to develop a vaccine against any of the other coronaviruses. However, that's a feature of the nature of those viruses. So if you recall, I discussed there were 4 circulating human coronaviruses that simply aren't a big deal. They don't kill a lot of people, give you your cough, your cold, and you move on. So in that sense, whilst it's an inconvenience, and if someone could do it easily, there would be a lot of money in it, there isn't a huge resource thrown at trying to develop vaccines against those. In the case of SARS and MERS, as discussed, we've effectively beaten both those viruses via public health measures, in which case, again, the logic and necessity of a vaccine, whilst it would be nice to have, diminishes. So that's not to say then that there aren't significant grounds for optimism. I think the most positive thing from a biological point of view is that it seems generally accepted this is a very stable virus. It's not mutating in a significant way. It hasn't yet, and even if it were to, it would be unlikely, as I understand it, to change so significantly that it would derail the vaccine finding process. It would involve tweaks and perhaps add some time, but it shouldn't be fatal to it. That's a real benefit if you compare it to something far more insidious, such as the HIV. That as a virus is a much more difficult foe. I believe 60 or 70 strains of it. So even if you found one against one, it's not going to be effective against all. The nature of the disease means that it resides latent in cells and you don't necessarily know it's there, and then re-emerges, makes it even harder to develop a vaccine against. So we're not in that territory. Other grounds for optimism are the level of resource being thrown at it. And I think as well, the speed with which a lot of this has been done, the genome sequencing happened very quickly, and there's a lot of new techniques which are being thrown at this virus in an attempt to try to do something more quickly. Typically, what happens when you try to create a vaccine, essentially you just create an attenuated or weakened form of the pathogen that you present and inject or ingest. It then will never develop as serious infection. Your immune system will beat it off easily enough, develop antibodies, and then you have your immunity. In this case, there's looking at even more advanced techniques basically to create what is known as an antigen vaccine. In essence, that would be simply creating the code for that spike that sits on the outside of the cell, the receptor, which is something that the antibodies recognize. So that would simply mean that you would be presented with that rather than a weakened version of the vaccine, just its marker, and that would be enough for the immune system to understand, learn what it was, and then when the real virus came, the antibodies would just attack the receptor regardless. So that gives hope, and I think obviously you will have heard timeframes somewhere in the region of 12 to 18 months. Obviously, that comes with a health warning that this is a new pathogen. We haven't vaccinated against it before. Whilst there are grounds for optimism, it's still a grey area. We aren't dealing in certainties on that timeframe front, or indeed potentially, although I think less likely. There is a risk that getting a vaccine comes too late. I think that is something that you couldn't rule out at this stage. And I think then the last thing would just be on the role of this becomes a multifaceted and quite an intricate argument. So really, if we were to talk about significant mutations, that would either be in how infectious the disease came. So if you imagine an R0 shifts from 3 to 4 or 4 to 5, then the risk of the things bursting out more becomes more pronounced, or a change in how deadly the disease was. So suddenly started to kill 5% of people. I mean, as that seems unlikely, but that would be a big jump. But those two things, I think the first thing to say is that traditionally with viral mutations, the tendency would be to become a weaker form. If you imagine, and again, you will have heard me use these examples quite a lot, but I think they are interesting comparators. MERS killing 30% of people, obviously that is being so deadly is not good for the virus. Not only in terms of the fact that that person once dead can't then be moving around spreading the virus, but also that attracts then the attention of people who look to distance themselves, and a public health response. So if there would be a tendency from an evolutionary perspective, viruses will tend to mutate into weaker forms rather than stronger forms. If they turn stronger, that usually is to their disadvantage. By stronger, I would mean particularly more deadly. If this were to shift to become something more like SARS and MERS and immediately target the lungs without that asymptomatic spread period, it would become much more easy to contain. But then on the upside, if it were to follow that pattern of becoming less deadly, well, that immediately, as you'll understand, is a benefit, because it wouldn't matter so much even if the R0 were to go up alongside it, because if more people are getting a milder form, then the impact on lockdowns and on health services goes away. So it's complicated, and again, that is a huge grey area, but probably I would tend towards the argument that mutation would likely be to our benefit than not. Although again, that would come with a caveat in terms of the vaccine. Obviously, if it changed significantly and we still wanted and needed that vaccine, then that becomes a problem. Although, as discussed previously, I think that we should hopefully avoid that. But again, things to think about. Obviously, the big question is, how long does all this take? What's the time frame? I think the overall answer is to say it's very difficult to say. There's a huge number of factors to consider in trying to work out all of this. Even trying to work out, precisely when an epidemic curve will peak is very difficult. This slide really is just to set out an example of how things could progress from probably a probable best case or to a worst case. I think the best case and the worst case are unlikely for various reasons, mostly because I'd be more optimistic about the vaccine prospects than that outlier case. And the best case, I think that implies a sort of perfect model of human behavior, which we simply aren't going to see as not realistic. So the likeliest scenario there is an attempt to frame a rough idea of how this is likely to progress. But you'll see even within that, there's significant variability and significant uncertainty, and it may be that something certainly could happen, particularly on the treatment side, that would change all of this quite rapidly. If you developed a very successful antiviral, this problem really becomes significantly less. If there was a significant mutation towards a much milder version of the disease that became dominant, that would hugely change the game as well. So again, difficult, but again, that should give you an idea. I would also suggest that you need to be constantly updating your assessments and forecasts in light of technological developments and our understanding of the virus. That's crucial, but that should give a flavour of how we're looking. But I think even in the best case, we're looking at a year of difficulty. I think probably 2 years of disruption sounds most plausible, although again, contingent on so many different factors that difficult to be precise about. I think lastly, really just a health warning about all of this. I see a lot of very confident predictions by people who are experts in one domain who I don't think have always very well considered the impact of other domains. To understand this, you need to understand, not necessarily just virology, epidemiology, economics, human psychology, politics. It's a systemic crisis which isn't necessarily amenable to a lot of siloed approaches to understanding it. I think I'd particularly flag up as a big unknown is the behavioural science sort of element to this. Obviously, there are people within that discipline advising governments. There's a lot of very shaky, in my view, ideological and academic foundations for a lot of research and knowledge within that sphere, which makes what they have to say, I think, of dubious validity. The simple truth is how well people respond to these lockdowns, what their reaction will be, is a significant unknown. And that is a huge compound problem. I think as well, the use of models obviously carries a health warning. These are projections based often on very imperfect data, particularly any that are relying on data out of China or, trying to project based on data from Iran. A model is only ever as good as its inputs. And, people really need to be aware of that. As a result, forecasting will change regularly. We will understand more about this virus as time goes on, hone our knowledge, hone the models. We'll get better at it, and forecasting will get better. But there'll need to be a real flexibility and a recognition that for now, there's going to be quite a lot of uncertainty, and preparing for a variety of scenarios is going to be the safest approach, rather than imagining that right now we can delineate a clear path through, even, on a sort of particularly short-term basis. There's so many unknowns and so many potential game-changing developments within the scientific field that means all of this is highly mobile. And that gets then into, what this really tells us about wider risk. Obviously, we'd be very focused right now on the epidemics, the curves. However, already, the shift really should start to be on, particularly the economic fallout of all of this. To see the joblessness figures out of the US alone, the political debate that's now opened up over euro bonds within the eurozone, common debt instrument. The ramifications of those will live with us far beyond these present epidemics, which, whilst will dominate our psychology in the short term, shouldn't, I think, dominate too strongly our assessment of risks and what the business environment and political environment will be in the years and decades that come on. But also trying to think about those things is contingent on the progress of the epidemic and the scientific changes. And so I think it's very much a case of trying to strike that balance between confidence about what we can meaningfully talk about now and in the future, and avoiding over and under extrapolation, I think is key. See perhaps too much of a rush, both from people to say that this will sweep away everything and that this will change nothing. And neither approach seems particularly prudent. That concludes this presentation. Obviously, if there are any questions or follow-up or anything you'd like to ask or know, we are, of course, here to help and happy to do so. Thank you very much for listening.